Welcome to the Deep Dive, the place where we sift through the sources, discard the noise, and bring you the detailed insights you need to truly understand the biggest topics shaping our world. Today, we're going beyond the initial headlines of a disease that dominated global life for years. COVID-19. We are moving past the immediate news flashes and focusing on the dense, complex, scientific, clinical, and societal knowledge derived from years of subsequent deep research. Our goal is to give you a shortcut to being fundamentally well-informed on this global event.
That's absolutely right. The sources we've gathered cover, well, a massive amount of territory, and our mission today is to provide a comprehensive, structured view. We will examine the disease from its initial nomenclature and agreed-upon origins to its deep, systemic impacts on the human body, the fascinating way the virus exploits our own physiology, and the surprising genetic and social factors that determine individual prognosis. We want to show you the full, nuanced picture of what was actually learned about SARS-CoV-2.
Okay, let's unpack this, starting at the very beginning, the name. I remember the sheer confusion and the rapid changes in terminology early on. For a learner trying to grasp the foundation, what do the sources tell us about the formal naming process and why it changed so quickly during that initial outbreak?
Right. The initial naming was, well, it was a flashpoint of public health policy versus cultural impulse, really. When the disease first emerged, centered in Wuhan, China, people naturally used descriptive terms. Coronavirus, Wuhan coronavirus, or even Wuhan pneumonia.
And the WHO had to step in because they had established guidelines against using geographic locations and names specifically to prevent that very public stigma, right?
Precisely. That guideline, established back in 2015, aimed to stop the stigmatization of specific regions or groups of people. Diseases previously named after places like Spanish flu or West Nile virus often led to discriminatory practices. So by January 2020, the WHO recommended interim, sort of technical names like 2019 and COVID.
But the official names that stuck came shortly after, in February 2020. What are those official names and how are they specifically defined, just so we're clear?
Yeah, good point. On February 11th, 2020, two distinct official names were announced. The disease itself was named COVID-19, which is an acronym for Coronavirus Disease 2019, and the causative agent, the virus, was named SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. This links it genetically to the original SARS virus from 2003.
That distinction, disease versus virus, is critical. Okay, so if we understand the name, we must address the origin. While there has been, well, significant debate in the public sphere, what is the overwhelming consensus drawn from the detailed scientific sources regarding where SARS-CoV-2 came from?
The consensus among the sources is pretty firm. The virus entered the human population through natural zoonosis, which means it originated in animals and spilled over into humans. This is the same prevailing scientific belief applied to the origins of SARS-CoV-1 and MERS-CoV. The first confirmed human infections were identified in Wuhan, China, back in December 2019.
The public conversation around origins was often fraught, focusing on specific theories. How did the sources address the mechanism of that natural spillover?
Well, the genetic analysis strongly supports the theory that SARS-CoV-2 descended from a coronavirus that naturally infects wild bats, specifically the Rhinolophus sinicus, or Chinese horseshoe bats. It's believed that the virus likely passed from the bats through an intermediary wildlife host, a step needed for the virus to mutate and gain the ability to efficiently infect human cells. And this event was strongly linked to the live wildlife trade active at the Huanan wet market in Wuhan.
So the scientific sources point to a natural but potentially preventable point of transmission linked to commerce and wildlife contact. And the research didn't stop there. It tied this event to a much larger global context, didn't it?
That's a crucial insight, yes. The sources, including research supported by the EU, connect this specific spillover event to broad, ongoing global issues. Factors like climate change, extensive natural ecosystem destruction leading to closer human-wildlife interaction, and the global wildlife trade system. Well, they all increase the likelihood of a zoonotic spillover event happening in the first place. For instance, climate change influences the distribution of bat species, potentially bringing them into new areas closer to human populations. It forces us to look beyond a single market and recognize the systemic environmental vulnerabilities that enable pandemics.
That sets the framework. Okay, now let's move into what the virus actually did to people, the clinical picture. The sheer variability of COVID-19 was one of its defining and most confusing characteristics early on.
Oh, absolutely. The variability was immense, and it changed over time as new variants emerged. For instance, later Omicron variants tended to cause less severe symptoms than, say, the initial Alpha or Delta waves, often affecting the upper respiratory tract more than the lungs. But regardless of the variant, the disease presented with highly diverse symptomology, just a huge range.
Researchers managed to categorize these into three primary symptom clusters, which helps simplify the chaos a bit. What were they?
Yeah, we can categorize the most common presentations into three main areas. First, the respiratory cluster, which includes the classic signs, persistent cough, high fever, and shortness of breath or dyspnea. Second, the musculoskeletal cluster, which often involves systemic symptoms like intense muscle and joint pain, headache, and that profound fatigue that just lasts for days. And third, the digestive cluster, where we saw abdominal pain, vomiting, and diarrhea. This highlighted early on that this was definitely not purely a lung disease.
And what about those unique, almost strange manifestations that were so characteristic early on, the loss of smell and taste?
Right. The sudden and complete loss of taste, ageusia, and loss of smell, anosmia, was highly characteristic of the original strains. Studies reported this in up to 88% of symptomatic cases, often occurring without typical prior ENT issues like a blocked nose. That was a massive red flag for people. We also saw unique dermatological and peripheral manifestations, most notably COVID toes, which involve swelling and discoloration turning purple of the digits, alongside general conjunctivitis or eye irritation. Really unusual stuff.
So, if the symptoms were so varied, how did the majority of symptomatic cases actually progress? We need to understand the statistical risk here.
Yeah, the statistics reveal a distinct spectrum of disease progression, often presented in the 81-14-D5 rule. The vast majority, 81% of symptomatic people, developed only mild to moderate symptoms. That could include mild pneumonia, but nothing requiring advanced intervention. However, the curve steepened rapidly for the minority.
Okay, so what about the other groups?
14% developed severe disease. This is defined by the need for hospitalization, often requiring high-flow oxygen due to dyspnea and hypoxia, or showing extensive lung damage specifically, more than 50% lung involvement visible on imaging scans. Then, 5% progressed to critical illness. These patients required immediate ICU admission due to the onset of respiratory failure, septic shock, or multi-organ dysfunction, often needing mechanical ventilation or dialysis.
And this leads directly to the core challenge of containment. The invisible spread, the asymptomatic and pre-symptomatic carriers.
This was the defining feature that separated COVID-19 from many prior epidemics, wasn't it? Sources consistently show that at least one-third of infected people, and some systematic reviews put this figure as high as 44%, never developed noticeable symptoms at any point. Critically, these individuals could still transmit the virus. Very effectively, in fact.
And even those who did eventually get sick were spreading it before they knew they were ill, that pre-symptomatic period.
That's the pre-symptomatic spread, which was, frankly, revolutionary in public health terms. Infectivity could begin 4 to 5 days before the individual experienced their first symptom. This phenomenon entirely broke traditional disease containment models that rely on isolating people after they feel sick. By the time symptoms appeared, community transmission was already well underway.
And how long could someone remain infectious?
Well, the duration of infectiousness varied dramatically. For typical mild or moderate cases, it was generally up to about 10 days post-symptom onset. But in severe cases, or for individuals who are immunocompromised, viral shedding and the infectious period could be protracted, lasting up to 20 days, necessitating much longer isolation periods.
The effects often didn't end when the acute infection cleared, though. We must now talk about the lasting challenge, long COVID.
Long COVID, yes. Defined by the persistence of symptoms lasting months or even years after the initial infection. It truly defined the protracted impact of the pandemic, evolving into a multi-systemic chronic condition that still affects millions. Multi-year studies are only now beginning to reveal the true depth of the damage.
What were the staggering incidence rates we saw? It wasn't just the severely ill, right? Even people with mild initial infections were affected.
The rates really underscore the gravity. For people who were not hospitalized, the incidence of developing long COVID ranged from 10% to 30%. That's potentially 1 in 3 non-hospitalized cases. However, for those who were hospitalized with severe disease, the rate was over 50%. It's clear that being hospitalized for acute COVID-19 carried something like a coin flip risk of developing long-term debilitating symptoms.
And what did the sources show regarding the specific lasting damage across different organ systems? What kind of symptoms are we talking about?
The damage was extensive and often cyclical. People reported cycles of good and bad days. The most common complaints included severe, debilitating fatigue and persistent headaches. In terms of lasting organ damage, the lungs were obviously severely affected. Pulmonary fibrosis, that's scarring and thickening of the lung tissue, was observed in roughly 1/3 of survivors investigated. even in some cases where the initial acute infection was considered mild. While some sources suggested slow improvement over many months, the structural damage was a profound observation.
We also saw striking evidence of lasting neurological and psychological impact. Can you quantify how significant these effects were? That sounds particularly worrying.
The neurological findings were, yes, particularly concerning. Studies conducted 2 years post-infection revealed increased risks for serious conditions. This includes significant cognitive deficits, often described as brain fog, and alarmingly increased risks for psychotic disorders, seizures, and even dementia. This is a deep, lasting footprint that goes far beyond simple fatigue. It's a measurable alteration in cognitive and mental health function.
Okay, that sets the stage for the next crucial question. How exactly does this virus, SARS-CoV-2, manage to cause such widespread and lasting damage across so many different systems? Let's dive into the pathophysiology.
Right. Understanding the pathophysiology means understanding the virus's molecular key, essentially. SARS-CoV-2 accesses host cells using a specialized surface structure, the spike glycoprotein, to bind to a highly specific cellular receptor, the angiotensin-converting enzyme 2, or ACE2 receptor.
ACE2. That receptor was a huge focus during the early stages of the pandemic. Why is the distribution of ACE2 across the body so central to the disease's varied symptoms?
The location of the ACE2 receptor basically dictates the target organs. It is most abundantly expressed on the surface of type 2 alveolar cells in the lungs, making the respiratory tract the primary site of infection and initial viral replication. That's why we see the lung effects first. However, ACE2 is not exclusive to the lungs. It is also highly abundant in the glandular cells of the gastric, duodenal, and rectal epithelium, which explains why we saw that common digestive symptom cluster. Furthermore, it is present in the heart, kidneys, and blood vessels, facilitating systemic spread and damage throughout the body.
So in the lungs, the classic sign is those ground glass opacities, the white patches you see on CT scans. What does the virus actually do once it's inside those alveolar cells?
Well, the primary pathological outcome in the lungs is diffuse alveolar damage, DAD. This is severe inflammation and destruction of the air sacs. The white patches, or ground glass opacity, GGO, are indicative of fluid buildup in the interstitial space. But the sources revealed an additional, quite unique physical mechanism of lung clogging.
Oh, what was that?
Medical research pointed to the possibility of a hyaluronic storm. Hyaluronic acid is a substance found naturally in the body, but when the virus attacks the alveolar cells, it can trigger an excessive production of a clear, jelly-like, highly viscous fluid rich in hyaluronan. This physically floods and clogs the airways alongside the DAD, severely impairing oxygen exchange and contributing significantly to acute respiratory distress syndrome, or ARDS.
Wow. Okay. If the respiratory damage is overwhelming, what about the neurological damage? You mentioned the brain aging effect, yet the brain itself has relatively low ACE2. How did the virus or the resulting disease cause such dramatic neurological effects?
This is where the mechanisms become complex and highly insightful. For the loss of smell and anosmia, research was pretty clear. The virus targeted and infected the support cells in the olfactory epithelium. These support cells are necessary for the function of the olfactory neurons, but the neurons themselves were generally spared from direct infection. So the damage to the support structure caused the temporary or sometimes permanent sensory loss.
But the long-term brain tissue loss is a different and maybe more terrifying mechanism, right? That wasn't direct infection either.
Generally not, no. While the virus is usually not detected in the central nervous system, CNS, of most living patients with neurological issues, the systemic inflammation appears to cause remote damage. Studies, including those focused on post-Omicron infections, starkly indicated that COVID-19 infection may cause observable brain damage, equivalent on average to at least 1 extra year of normal aging. Specifically, researchers observed measurable tissue loss and atrophy in brain regions connected to the sense of smell and memory processing. The neurological consequence is a major non-respiratory footprint of the disease, a really serious long-term issue.
We also noted severe effects on the cardiovascular system and blood. It sounds like the virus didn't just attack cells, it fundamentally altered how blood behaved.
It absolutely did. The sources documented high rates of acute myocardial injury, heart muscle damage, and inflammation. But perhaps the most dangerous systemic complication was the high incidence of thrombosis abnormal blood clotting. This led directly to devastating complications, including ischemic strokes and pulmonary embolisms, even in relatively younger patients without prior risk factors. The systemic inflammation and damage to the endothelial lining of blood vessels caused these clots. Critically, structural changes to blood cells themselves were observed persisting for months after acute recovery, indicating potential long-term cardiovascular risk.
And all the systemic damage often culminates in the term we heard used for the most severe critical cases, the cytokine storm. Can you break that down?
Yeah, the cytokine storm represents the body's devastating immune overreaction. If we connect this to the bigger picture, severe COVID-19 often resulted in a state of systemic hyperinflammation. Pro-inflammatory cytokines like interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-A, are released too quickly and in excessive amounts, essentially flooding the body.
So the immune system, designed to protect us, becomes the leading cause of death in those severe cases.
Exactly. This uncontrolled systemic response drives ARDS, widespread vascular damage, multi-organ failure, and exacerbates the risk of thrombosis. It's a runaway feedback loop. And what's fascinating here is the complex role played by key immune defenders like interferon alpha. Interferon is crucial for eliminating infected cells. However, sources noted that the signaling pathway initiated by interferon alpha also upregulates the expression of ACE2, the very receptor the virus uses for entry.
Wait, that is an astonishing paradox. The body's defense mechanism inadvertently opens more doorways for the enemy.
It creates a dangerous cycle. The severity of the cytokine storm and the patient's ultimate fate were often determined by this delicate competitive balance between the protective function killing infected cells and the positive feedback loop of upregulating viral entry points. Really complex biology at play.
Before we pivot to prevention, let's quickly address the pregnancy-specific vulnerabilities the sources highlighted. That seemed like a key finding.
Yes, pregnant women were clearly identified as a vulnerable group, primarily due to physiological changes that occurred during gestation. They experience reduced total lung capacity naturally, which makes fighting a severe respiratory infection harder. Furthermore, they naturally have higher baseline levels of circulating coagulation factors, which exacerbates the thromboembolic risk already present in severe COVID-19. Infection correlated with unfavorable outcomes like fetal growth restriction, preterm birth, and sadly, perinatal mortality. Unvaccinated women in the later stages of pregnancy were repeatedly found to be at the highest risk for needing intensive care.
Okay. This moves us into transmission, prevention, and public health measures. When the pandemic started, we were all focused on wiping down groceries, washing our hands constantly, and distancing. But the research fundamentally redefined our understanding of how respiratory viruses like this are transmitted.
This is arguably one of the most critical long-term scientific shifts of the pandemic. Initially, the focus was heavily on contact transmission via surfaces, known as fomites, and large respiratory droplets that fall quickly to the ground within, say, 6 feet.
But the sources confirmed the fundamental shift to airborne spread being dominant. Why did that distinction matter so much?
It matters hugely. Transmission occurs mainly through inhaling air contaminated by infectious respiratory particles. The key insight was the role of aerosols. While risk is highest in close proximity, small particles, specifically defined as being less than 100 micrometers in diameter, are light enough to remain suspended in the air for long periods, hours even. And they can travel over distances greater than 6 feet, especially in poorly ventilated indoor spaces. This revelation essentially reframed the disease as an airborne threat, more like measles or tuberculosis in its spread mechanism, rather than a primarily surface or large droplet-based disease like the flu was traditionally thought to be.
And this new understanding forces us to discuss the critique that emerged, known widely as hygiene theater. Let's unpack that thoroughly, because we all experienced it.
Right, hygiene theater. The virus can survive for hours to days on various surfaces, the longest survival times reported on materials like N95 respirators, glass, steel, and plastic. Early pandemic policy was heavily based on this survival data, leading to aggressive disinfection campaigns, spraying streets, closing playgrounds, constant surface wiping. However, as the aerosol data mounted, evidence consistently showed that contact with infected surfaces, fomite transmission, was not the main driver of community transmission. It could happen, but it wasn't the big problem.
All that deep cleaning.
Deep cleaning, disinfecting playgrounds, obsessive surface sanitization, the hygiene theater, was heavily criticized because it consumed vast resources and, crucially, gave the public a false sense of security against a virus primarily spread through the air we breathe. The sources noted that in most non-clinical settings, simple cleaning with soap and detergent, which disrupts the viral envelope, was sufficient. Aggressive chemical disinfection was largely unnecessary and misdirected effort against an airborne threat.
So if the primary route is airborne, What are the modern pillars of prevention identified by the accumulated research? Where should the focus really be?
The pillars reflect a focus on air quality and systemic protection. The first pillar is, unequivocally, vaccination. We saw the extremely rapid and highly effective development of mRNA and viral vector vaccines. It's important to acknowledge that this breakthrough technology was recognized with a Nobel Prize, marking a revolution in preventative medicine. Vaccination dramatically reduced mortality and serious illness and was confirmed safe for vulnerable groups, including pregnant and breastfeeding individuals. Foundational.
Okay, pillar one, vaccines. The second pillar relates directly to the airborne threat and the need for, perhaps, structural change.
That's air hygiene. Ventilation became absolutely critical. Public health policy needs to focus on increasing the air change rate, how often the air in a room is replaced with fresh air. Also avoiding air recirculation without proper filtration, and using mechanical air filtration such as HEPA filters, especially in high-density areas like schools, offices, public transport. The research emphasized that risk increases exponentially in enclosed spaces where people exert themselves or raise their voice, like shouting or singing, as these activities dramatically increase the exhalation of infectious aerosol particles into the shared air.
Makes sense. And the third major pillar is masking, where the type of mask and fit were paramount.
Yes. Masking serves both as source control, limiting the outward spread from an infected person, and personal protection, limiting inward exposure for the wearer. But efficacy varied widely. Fitted N95 respirators, designed specifically for airborne hazards, clearly outperform surgical masks, which are primarily designed to block large droplets and splashes. The sources indicated that simple cloth masks, while better than nothing, offered only marginal protection against inhaling those smaller aerosolized particles. Fit was also key. Gaps around the mask reduce effectiveness significantly.
Okay, those are the prevention pillars. Beyond prevention, what did the sources tell us about the ultimate breakthroughs in treatment and management strategies that actually saved lives once someone was infected?
For acute care, the primary treatment remained symptomatic and supportive. Rest, fluids, managing oxygen levels carefully. But we saw two major pharmacological breakthroughs that fundamentally changed outcomes for severe cases. First, dexamethasone, an inexpensive, widely available glucocorticoid. The steroid was strongly recommended for severe hospitalized cases, patients requiring oxygen or ventilation, because it demonstrably reduces the risk of death, specifically by dampening that systemic hyperinflammation, the cytokine storm we discussed earlier.
Right, tackling the immune overreaction. And the newer antivirals, used earlier in the disease progression for high-risk patients.
Exactly. Antivirals like nirmatrelvir-ritonavir, known commercially as Paxlovid, and remdesivir are used for high-risk patients who have mild to moderate symptoms. Their function is to prevent viral replication early on, thereby stopping progression to severe disease and hospitalization. They need to be given within the first few days of symptoms, typically. It's also a reminder of the scientific journey, Early efforts to repurpose drugs, like hydroxychloroquine, were later found through rigorous trials to be ineffective or even harmful, underscoring the necessity of good clinical data.
Let's turn now to the final and perhaps most sobering part of our deep dive: prognosis, mortality, and the disparities in risk. To accurately convey the true danger of COVID-19, we have to start by clarifying two specific metrics that are often confused by the public.
Yes, this is the distinction between the case fatality rate, or CFR, and the infection fatality rate, or IFR. This is absolutely crucial for anyone trying to interpret pandemic severity data accurately.
Let's define them clearly and explain why one is a far more accurate measure of the disease's true impact on a population level.
Okay. The case fatality rate, CFR, is calculated by dividing the number of deaths by the number of confirmed diagnosed cases. It's a figure that's highly influenced by how much testing is being done. Globally, the reported death-to-case ratio was around 1.02% in early 2023. However, since many infections, especially mild or asymptomatic ones, go undiagnosed, the CFR almost always overestimates the danger to the entire population of infected individuals.
So the CFR is based only on the cases we know about.
Exactly. The infection fatality rate, IFR, is the key metric for understanding true severity. This is calculated by dividing deaths by the total estimated number of infected individuals, critically including those who were asymptomatic or undiagnosed. The IFR is the real gauge of the disease's intrinsic severity within a population. It tries to capture everyone who got infected.
And when you analyze the IFR data, what stands out immediately is the profound age gradient of risk. It wasn't the same risk for everyone.
Not at all. The IFR is exponentially age-dependent. A comprehensive systematic review looking at data up to December 2020 revealed this stark gradient. For a 10-year-old, the IFR was incredibly low, about 0.002%. For middle-aged adults, say age 35-44, it jumped significantly to 0.068%. For those 55-64, it was 0.75%. And for the elderly, aged 85 and older, the risk was staggering, reaching approximately 15%, 15%.
I think we need to pause there and really drive home what that means for a typical middle-aged adult listening to this deep dive. How does that IFR compare to risks we consider, well, normal?
It forces a powerful reassessment of risk perception. Analysis of these IFR rates showed that the risk of death from COVID-19 for a middle-aged adult was estimated to be 2 orders of magnitude greater. That means about 100 times greater than the annualized risk of dying in a car accident. Furthermore, even before the highly effective vaccines became available, COVID-19 was determined to be far more dangerous to this middle-aged cohort than seasonal influenza typically is. That data point radically altered the perception that this was just like the flu for younger or middle-aged adults.
Wow, okay. Beyond age, comorbidities were clearly the biggest drivers of fatality across all age groups, weren't they?
Oh, absolutely massive risk factors. An Italian report on fatalities found that 96.1% of those who died had at least one pre-existing condition, with the average person who died having something like 3.4 underlying diseases. The top comorbidities were consistent globally. Hypertension, or high blood pressure, was present in about 66% of deaths. Type 2 diabetes in roughly 29.8%, and ischemic heart disease in about 27.6%. These conditions compromise the cardiovascular system and immune function, making things like thrombosis and the cytokine storm much more likely and much more deadly.
And we also saw connections to lifestyle and environmental factors influencing morbidity and mortality, things beyond just pre-existing disease.
Yes, smoking was consistently shown to be a major enhancer of poor outcomes, likely because it compromises existing lung function, a major factor in countries like China, where male smoking rates are particularly high. Also, chronic exposure to air pollution, which interestingly affects the very ACE2 receptors that the virus uses for entry, was shown to enhance both morbidity and mortality. And one less discussed but fascinating risk factor related to hormones. Men with untreated male hypogonadism, low testosterone, were found to be 2.4 times more likely to require hospitalization if they contracted COVID-19.
Let's look at the disparities the sources documented, sex and ethnic differences. Starting with sex, why were men globally at higher risk for severe outcomes?
Men were consistently more likely to be hospitalized, admitted to the ICU, and die from COVID-19. For example, data from China showed a death rate of about 2.8% for men versus 1.7% for women early on. Potential explanations are probably multi-layered, generally higher rates of lifestyle factors like smoking in some regions, perhaps some underlying biological immune response differences, and also the tendency for men to develop severe comorbidities like hypertension and heart disease at younger ages than women.
And in terms of ethnic disparities, particularly in places like the US and UK, the sources point overwhelmingly towards structural factors rather than intrinsic biology, correct?
Absolutely. In the US and the UK, for example, African Americans, Native Americans, Hispanic populations, and other minority groups experience disproportionately high rates of death and severe disease. The sources link this directly to structural inequities, not genetic predisposition. These communities were more likely to live in crowded, multi-generational housing, be concentrated in high-risk essential worker jobs that require public exposure during lockdowns, and suffer from poorer access to quality health care for managing the underlying chronic conditions that worsen COVID outcomes. The pandemic really just exposed and amplified existing social fissures.
And yet, amidst all these social and environmental factors, there is one incredible biological intersection of genetics and ancient human history that the sources revealed: the Neanderthal connection.
Yes. This is where it gets really interesting and connects ancient history to modern pathology in a way no one expected. While specific contemporary genetic variants like the DOCK2 allele in some Asian populations were found to influence outcomes, the most striking finding was linked to our deep evolutionary past. Genetic variants located at chromosomal region 3, which are known to be associated with European Neanderthal heritage inherited from interbreeding tens of thousands of years ago, were found to be linked to a significantly greater risk of developing a more severe form of COVID-19, requiring hospitalization.
So our evolutionary history, dating back tens of thousands of years, literally played a role in our vulnerability to this modern virus. That's mind-blowing.
It's a profound realization, isn't it? This specific segment of DNA, a relic of admixture between modern humans and Neanderthals, estimated to have occurred perhaps 50,000 to 60,000 years ago, primarily affecting people with ancestry tracing back to Southern Europe and South Asia, unexpectedly increased the risk of severe COVID-19. It's a powerful illustration of how the genetic lottery of deep history can impact contemporary health outcomes in unpredictable ways. Separately, you might remember early research suggested a link between blood type, type A higher risk, type O lower, but later, broader international studies did not confirm this link universally as a significant independent risk factor. That initial finding didn't really hold up strongly.
Okay. So what does this all mean? We've covered an enormous amount of ground. Everything from the scientific consensus on zoonotic origin and the crucial difference between CFR and IFR to the viral entry mechanisms via ACE2, the complexity of the body's self-inflicted damage in the cytokine storm, the shocking figures on long COVID prevalence and its neurological impact, and the total overhaul of transmission understanding, shifting focus decisively to aerosols and ventilation.
I think the key takeaway for you, the listener, is this. The pandemic served as a global stress test. It exposed not just a new viral threat, but existing deep vulnerabilities in our individual biological systems, in our ancient genetic past, and crucially, in our modern societal structures and inequalities. The complexity of the disease trajectory, how a single virus interacts with both our individual physiology, our genetics, and our vast socioeconomic landscape, underscores the absolute necessity of adopting a comprehensive, holistic approach when analyzing and preparing for future global health crises. We can't just look at the biology in isolation.
A holistic approach that acknowledges both biology and structural risk. Okay. To leave you with a final thought to ponder, consider this. The IFR analysis showed COVID-19 posed a statistically greater danger to a middle-aged adult than a fatal seasonal flu or even their annual risk of dying in a car accident. What implications does that specific risk assessment, combined now with the solid understanding of primarily airborne spread over potentially long distances indoors, hold for how we fundamentally need to design and regulate indoor air quality and ventilation standards in our schools, our offices, and our public transport systems going forward? Something to think about.